Hello guys, a very good evening to all of you and I welcome all of you to today's session. And I'm sorry I could not do the session yesterday because of some obligations. And anyways, whatever we were supposed to do yesterday, we'll do it today. And first of all, tell me, how are you guys holding up? It's the most difficult period. The festival time is here, and it's the most difficult time when everybody is celebrating around you, and you still have to keep hooked on yourself to your textbooks and all. So guys, good evening Purnima, good evening Varun. uh, कैसे हो आप सब? सत श्री अकाल गुरमीत सिंह, सत श्री अकाल. So guys, I hope all of you are doing well and moving on with your studies, and let's begin with what we are supposed to do today. I'm great, Raja Bisht. I'm great, thanks a lot. So this is what we are supposed to do today. The rest of antimicrobials, antibiotic हमने किया था पिछली बार. We discuss antibiotics today. The rest of antimicrobials, antiviral, antifungal, whatever is there, we're gonna discuss today, right? And I had posted, this is for endocrinology. I had posted the schedule yesterday itself, but this is I'm showing it here because many of you guys, you message me that you tell me the chat box that you're not in social media, right? If you're not, you can take a screenshot of the next week. It has already begun from today. Anyway, so let's begin with today's questions, guys. A 37-year-old woman diagnosed with pulmonary tuberculosis was started on standard regimen with first-line drugs, after which the disease marginally improved. Thus, susceptibility testing was done, which showed resistance to isoniazid. It was overcome by doubling the dose. So there was isoniazid resistance. We still continued isoniazid by just increasing the dose 2 times. Which of the following gene might be associated with the resistance in this case? Samriddhi Madik, thanks a lot. Thanks a lot, guys. All right, so what is the answer? See, resistance, these MCQs on isoniazid resistance has been asked both in INI-SET and NEETPG in your last exams. So I have included an MCQ that is a little bit different, right? So where is it that I can use it? I can use it even if there is resistance, right? There is only one mechanism, and we have discussed that, right? All right, so many of you have given the right answer. See, two important resistance are, there are 3 RPO-B gene. First of all, RPO-B gene mutation, it is associated with rifampicin, right? Whereas these 3, they are associated with isoniazid. These 3, CAT-G, it can undergo mutation. Cas-A gene can undergo mutation. INH-A gene, it can undergo over expression. Now you understand pretty well. Whenever there is mutation, right, the drug will not be effective because mutation will change the target, isn't it? Mutation changes the target. But in case of INH-A gene overexpression, there is an increased number of an enzyme called as protein reductase, and this is blocked by isoniazid. Just imagine, if protein reductase is increased, I can increase my dose of isoniazid, double it, it would still be effective. So there are 2 possible MCQs here. I can use INH-A gene overexpression is what I can still use by doubling the dose. Second point they can ask you here is cross resistance. There is something called as cross resistance to a drug called as ethionamide, right? Isoniazid can have cross resistance to ethionamide, and that is because of which gene or what is the mechanism? Again, your answer would be INH-A gene overexpression. Third MCQ, if they ask you severest resistance, severest mechanism of resistance, it would be because of CAT-G gene mutation. So guys, these are the possible MCQs that can be asked, and many of you have given the right answer, and that's great. Now, second question, which of the following statement is false about delamanid? Now remember, in second line drugs, there are many drugs in second line. But if I have to put my money on second line drugs where MCQs would be asked, these are two important drugs, bedaquiline, delamanid. This is where MCQs will be asked. So I need to be sure about these drugs. So I've included one MCQ on delamanid. Mechanism similar to metronidazole. So mind it, I'm asking which is false, right? High plasma protein binding, contraindicated in pregnancy, should be taken with food, right? So these are new MCQs, and if you'll answer such MCQs, because it's not a difficult MCQ, because if you remember the topic, I've taught bedaquiline, delamanid in detail, and if you remember that, I've made this MCQ from whatever possibly they can ask, right? Right, so which is false, guys? Which is false? What do you think? Actually, in these, only one person has given me the right answer. All are correct. All are correct. Here there is no wrong answer. So I just wanted to test. That. Do you know that topic or not? Right. So it has a mechanism similar to metronidazole because it belongs to a class called as nitroimidazole. Metronidazole is also a nitroimidazole. So they have similar mechanism in the sense that they produce free radicals. It has a high plasma protein binding, that is also correct. It is contraindicated in pregnancy, that is also correct. It should be taken with food, that is also correct. Now here, so all are correct. So there is no answer here. All are correct. Now, with respect to bedaquiline, there is one point. If you have my old notes from edition 5, make one small change. Bedaquiline this year, according to the recent guidelines, trials data that we have received, bedaquiline, it can be used in pregnancy. Bedaquiline. Now, mind it, delamanid is contraindicated in pregnancy not because it is teratogenic, right? But because we don't have sufficient data supporting its use in pregnancy. Now, that is something we already have with bedaquiline, and that is the reason why I can still use bedaquiline in pregnancy. I mean, I can already use it. So this small change, please add that to your notes, right? Now, let's come down to a clinical case. It's not a difficult one. 45-year-old man came to medicine OPD with complaints of decreased appetite, persistent nausea, abdominal discomfort, problem of multiple joints associated with pain, arthralgia. He was diagnosed with pulmonary tuberculosis and is a standard first-line regimen for last 20 days. Now look at the test. There is an increased ALT, AST, uric acid, and which of the following drugs most likely cause the patient's symptoms and signs? So as I said in the beginning, it's not a difficult one. Is not a difficult one because I have described the entire arsenal of toxicity of one first-line TB drug in this question, and it's not a difficult one. It's a very easy one, right? Come on, guys. Come on. Comment. Come on. What is the answer here? It's an easy one, guys. I've not given you one. I've given you 3 clues here. 3 clues: joint pain, arthralgia. Second clue was hyperuricemia. Third clue was hepatotoxicity. So, joint pain, hepatotoxicity, hyperuricemia. It's a triad. It's a triad that is seen with pyrazinamide. So see, if you are having a lengthy question, it does not mean it is difficult. You just have to fish out those important words in the question stem and find the right answer. So you can see it is as easy as any MCQ that can be possible in your exam, right? Next one, guys. For which of the following side effect rifampicin should be stopped and never restarted in a patient? never restarted in a patient. Hepatotoxicity, purpura, pulmonary syndrome, both B and C. Come on, guys, come on. A similar MCQ I had asked on Instagram as well. Right, I had posted it few days back on Instagram. Now, those who have mugged up or superficially, they'll go for option B as an answer. But now you have started throwing the right answer. The reason being, see guys, make it a point, never jump to conclusion for a right answer just by looking at one option. Right? Go through all the four options, weigh the options, then go for the kill for the right answer. So A, B, C, D. Now, there's something I've taught you. There are two side effects for which I have to stop rifampicin, never ever restart in his entire lifetime. And one of them is purpura, another is pulmonary syndrome, right? And that is the reason why. What's my answer? My answer is D, that is both option B and C are correct. Good evening, Pallavi. Good evening to all of you who have joined late. Very good evening to all of you. So both B and C are the right answer. So what you need to understand here is P for purpura and P for pulmonary syndrome, right? So remember this, P for purpura, P for pulmonary syndrome. If a patient develops, I'm never ever gonna prescribe, right? I'll not prescribe. So I'll not prescribe rifampicin. I'll not re-prescribe or prescribe rifampicin. P for prescribe, P for pulmonary syndrome, P for purpura. They might not give you purpura in the option. They might give you thrombocytopenia. Now see, that is the reason why I tell you, you have to learn the topic in deep. I mean, if there is purpura, you have to know that purpura is a presentation of what? Of thrombocytopenia, right? Tushar Bhargava, I'm great. See, pulmonary syndrome is a hypersensitivity reaction, right? And due to clogging of neutrophils and leukocytes, it causes a syndrome where you'll have different neutrophilic infiltrates in the lungs. That is called as pulmonary syndrome, right? All right. So next, move to another clinical case. 27-year-old drug abuser suffering from AIDS. Means whenever I look at it, one thing should come into my mind. Patient is immunocompromised, right? Emergency department with high-grade fever, headache, confusion, nausea, vomiting. Means symptoms are central in an immunocompromised patient. Nuchal rigidity, diplopia, loss of vision. That means it tells me about involvement of the meninges as well as the brain. So nuchal rigidity is there, meningitis possibly. Agglutination test gives capsular polysaccharide antigen. So this gives away the diagnosis. Meningitis, CNS symptoms, immunocompromised. Which of the following treatment would be most appropriate? So first of all, you have to make a diagnosis. So guys, what is the diagnosis? Come on. What is the diagnosis? All of you know what is this? What is the diagnosis? The diagnosis is cryptococcal meningitis, guys. Cryptococcal meningitis. Excellent. Kaushik Das, excellent. Cryptococcal meningitis. So what am I going to use here? A, B, C, or D? It is not streptococcal. It is capsular polysaccharide antigen. It's cryptococcal meningitis. So come on, guys, what is the answer? Right. So see, many times you might not get exactly the same thing that you have studied. Come on. Try to make a guess. Try to make a wild guess, guys. You cannot afford to leave such MCQs, right? You cannot afford to leave. So you know now, cryptococcal meningitis. I use IV Amphotericin B plus IV flucytosine, isn't it? This is what we study. But now tell me, is IV Amphotericin B plus flucytosine in the option? No, it is not there. Fluorouracil is an anti-cancer drug. Do I use it? No. So option B will not be the answer. Option B will not be the answer, guys. Now try to understand this. IV flucytosine is a very toxic drug and it might not be available everywhere. So if I don't have flucytosine, I can also use fluconazole. I can also use fluconazole, right? Now, can you tell me now what is the answer here? You understand? It won't be flucytosine fluconazole. Fluconazole ceftriaxone has nothing to do here. My answer is A. Amphotericin B plus fluconazole. Amphotericin B plus fluconazole. So guys, try to understand the treatment modalities. Don't just mug them up, right? So I'll not combine fluorouracil. It's an anti-cancer drug. Colorectal cancer, anal cancer, right? All right, now this is an update question based upon an update that I had posted in the Marolinks group. Oteseconazole is a new drug that is approved this year, 2022, and it will be asked sooner or later. It will be asked. Why it will be asked? I'll tell you in a short while. It's a new antifungal drug approved for treatment of aspergillosis, mucormycosis, candidiasis, dermatophytes. Aspergillosis, mucormycosis, candidiasis, dermatophytes. Aspergillosis, mucormycosis, candidiasis, and dermatophytes. Right. What is the answer, guys? I had see, you can in the Marolinks group, whenever you go to Marolinks group, you can just search pharma update. Pharma update, you'll get one post. I have one post, and in that one post, you'll go into the comment section, and in that comment section, I have mentioned all the updates, including this drug. Now, guys, here the answer. No, see, such questions, if you don't know the answer, see, these are mostly asked in ionized set. And they are, they're highly ranked deciding MCQs. Here, your answer is candidiasis, and to be specific, vaginal candidiasis. So why oteseconazole has been approved for vaginal candidiasis? The reason is, for candidiasis, what is the drug of choice? Fluconazole. Now, tomorrow, when you become a gynecologist, you'll have a lot of females coming to you with vaginal candidiasis, and obviously, you'll be using fluconazole for treatment. And the problem that we are having nowadays with fluconazole is recurrence. Now, so this is a big headache for the gynecologists and for the patients. So the drug companies are involved in developing some drugs which can radically cure vaginal candidiasis, and one is an azole called as oteseconazole, and another new drug is beta glucan synthase inhibitor called as ibrexafungerp. Ibrexafungerp, although this is not the most ideal name. It's a very difficult name. So remember, two drugs for vaginal candidiasis. Oteseconazole is an azole. Ibrexafungerp is a beta glucan synthase inhibitor. Do you remember the class where we have caspofungin, micafungin, anidulafungin? And I don't need to tell you that how common is vaginal candidiasis in our world. It's a very common disorder, right? And for that, there's such a headache with fluconazole. We need newer drugs. So please add these two drugs into your notes. If you're having older notes, right? 2016, the 6th edition of Mero, I have updated this. Next question, a 62-year-old male suffering from diabetes mellitus, chronic renal insufficiency, presented to the OPD with symptoms of urgency frequency, right? He was diagnosed with a case of BPH and underwent TURP for same. After 1 week, he developed high-grade fever with chills, though he was given antibiotic prophylaxis. Urine culture test shows Candida albicans sensitive to most systemic antifungal drugs. A drug with which of the following mechanism of action will be preferred here, right? For option A, formation of holes in ergosterol. block of beta glucan synthesis, breakdown of fungal DNA, inhibition of microtubules. Right, guys, tell me, what is the answer here? So he's a patient of BPH, transurethral resection of prostate is done, and that can be associated with UTI, fungal infection, and here I need to use some drug. It has become a systemic candida infection. And come on, take some time, but do answer. Take some time, but do answer. You might get the answer wrong, but it is fine. We are not going to shoot anybody, right? Answer गलत होता है तो भी चलेगा, कोई फर्क नहीं पड़ता, कोई फर्क नहीं पड़ता. If answer is wrong, it's okay, but you have to attempt. You have to attempt so that you can understand if your thought process was right or wrong. Come on, guys, come on. All of you must attempt. Come on. Give me an answer. A, B, C, D. Whatever you think. Give me an answer. Is it A, B, C, or D? Does not matter. You're right or wrong. It's perfectly fine. Right? So we might have to mark wrong here so that we mark right in the exam. All right, systemic fungal infection, guys, and the drug of choice is Amphotericin B. The drug of choice is Amphotericin B, and there is an old mechanism of action you'll find in some textbooks. It is by formation of holes or pores in the cell membrane. The new mechanism of Amphotericin B is though that it sequesters ergosterol, and I have always encouraged you to remember both the old and the new mechanism, because you don't know, right? The professor is referring to which textbook, the having the old mechanism or new mechanism. So guys, option A is the right answer because it is systemic fungal infection. I'm gonna use Amphotericin B. It's a life-saving drug. Next one, it's a pretty simple one, direct one-liner. IV fluids used along with Amphotericin B are. So what are the IV fluid used? Normal saline, dextrose, ringolactate, both A and B. Dr. Z, if it is resistance, then option B. See, in case of resistance, yes, if there is Amphotericin B resistance, you can use, but Amphotericin B resistance is is not that common. It's not that common. All right, what is the answer, guys? A, B, C, or D? Normal saline, dextrose, ringolactate, both A and B. Come on, guys, come on. It's an easy one. It's not a difficult one. ये बहुत ही आसान क्वेश्चन में आता है. अगर ऐसे क्वेश्चन आप गलत करोगे, आप रेस से बाहर हो जाओगे. You cannot afford to do mistake in such questions. It falls into the territory of easy questions. It falls into the territory of easy question. In the section of Amphotericin B, remember what have I taught you? That Amphotericin B is given by intravenous route along with a carrier. That carrier is dextrose. So I dissolve it in dextrose and give it. But then Amphotericin B is nephrotoxic. And to prevent nephrotoxicity, I preload the patient before giving normal saline. So normal saline is given to prevent what? Nephrotoxicity. Dextrose is used at what? As a carrier, right? So that it can carry the drug into my body in an infusion. Both are used. So what is the better answer? Both A and B. Both A and B are right answer, right? So guys, this is, tell me, was this a difficult question? No, it's not a difficult one, right? Nephrolithiasis can be seen with all except. See, renal stones is a very commonly asked topic. So I've clubbed a bunch of drugs from antimicrobials which can cause renal stones, and I've made this MCQ for you guys. Endinavir, acyclovir, zidovudine, sulfonamides. Nephrolithiasis can be seen with all except. Come on, guys. Which is the answer? A, B, C, or D? Renal stones, nephrolithiasis can be seen with all except. Is it all except? Now, remember something. I'll tell you a basic concept here. Many of you might be confused with this fact that you know that drugs cause crystalluria. See, any drug, remember this, any drug that causes crystalluria, it has the ability to cause renal stones. So crystalluria का मतलब ही renal stones है दोस्तों. Friends, any drug that causes crystalluria can cause renal stones. So whenever I give a drug that causes crystalluria, what is the advice I give to the patient? Drink, 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 plenty of water, plenty of water. So now at least now can you tell me what is the answer? A, B, C, or D? Now tell me at least what is the answer? A, B, C, or D? Now you know the answer. You know the answer. It is C, zidovudine. Many of you have given the right answer, guys. Correct, correct, correct. Excellent. I'm proud of all of you. Zidovudine does not cause renal stones. These drugs, they will cause renal stones. Indinavir causes renal stones because these drugs, they get crystallized, and because of which they can precipitate and cause renal stones. In crystalluria, what could be the other way of asking an MCQ? They can ask you, which of the following drug can cause obstructive renal failure? Now try to understand. You have to understand the basic concept, right? You don't have to just mug up. Now, if I say obstructive renal failure, again, these drugs which cause crystalluria can cause obstructive renal failure by blocking your renal tubules. It's the same thing. It's the same thing. I just have to understand the consequences of crystalluria, right? Myoglobinuria can be seen with zidovudine, raltegravir, rosuvastatin, all of the above. What is the answer, guys? Myoglobinuria can be seen with zidovudine, raltegravir, rosuvastatin, all of the above. Myoglobinuria can be seen with zidovudine, raltegravir, rosuvastatin, all of the above. Come on, come on. So I've just given you, say, myoglobinuria will be a consequence of myopathy. So they might ask you myopathy, they might ask you myoglobinuria, they might ask you rhabdomyolysis. At the end of the day, all of these, they mean the same thing, right? And what is the answer? So guys, zidovudine causes or not? Yes. Raltegravir causes. I've taught you this. Statins cause myopathy or not? All of the above, guys. So these are three important drugs where, say, two from antimicrobials where MCQs can be asked. Zidovudine has been asked many times. Raltegravir has never been asked, but it can be asked because integrase inhibitors are nowadays first-line drugs. Statins, I don't have to remind you how many times they have asked. Statins can cause myopathy. What else? Fibrates can also cause myopathy, right? Fibrates can also cause myopathy. All right. A 45-year-old male suffering from AIDS for the last 5 years is on the first line regimen for treatment. He is presented to the OPD with symptoms of dyspnea, fever, non-productive cough. He was diagnosed as a case of CMV pneumonia and started on intravenous drug. The drug that he was started on is, again, it's a simple MCQ. Take your time. See, don't get overexcited and jump onto an answer, right? Process the question, analyze it, only then go for the right answer, right? So what is it? A, B, C, or D? Is CMV, cytomegalovirus, causing pneumonia? What is the answer, guys? A, B, C, or D? Come on, guys. What is the answer? A, B, C, or D? Ganciclovir, velaganciclovir, acyclovir, valacyclovir. What is the answer? See, if I want to use an oral drug for CMV, then I go for velaganciclovir more than ganciclovir, right? But if I want to use IV, I don't have well ganciclovir. The reason being, ganciclovir has poor oral absorption. That is why I have made a prodrug, Vela ganciclovir, for better oral absorption. But IV route oral absorption, there is nothing related to it. That is the reason why. If they have asked you here about an intravenous drug, your better answer is option A. Most of you have given the answer right, and I'm really proud of you guys. Most of you have. So remember, whenever they ask IV route, understand, or they ask severe infection, I go for IV drugs. So herpes virus, IV drugs, ganciclovir and acyclovir, these are preferred, right? Let's move on. Bone marrow suppression is seen with all except, again, bone marrow suppression is a common topic. So I've taken few important drugs that cause bone marrow suppression and I've clubbed them together into an MCQ, stitched them together. Zidovudine, ganciclovir, linezolid, oseltamivir, right? It's a very important topic, bone marrow suppression caused by which drugs, right? So it's seen with all except, so it's an except MCQ, all except MCQ. Bone marrow suppression is seen with all except zidovudine, ganciclovir, linezolid, oseltamivir. Bone marrow suppression is seen with all except zidovudine, ganciclovir, linezolid, oseltamivir. So guys, what do you think? What is the answer here? Excellent, guys. Excellent. All of you have given the right answer. Answer is oseltamivir. The very purpose of giving this MCQ is I just wanted to give you a bunch of drugs. I wanted to give you a bunch of drugs that cause bone marrow suppression that you can remember in one place: zidovudine, ganciclovir, linezolid, and all of them they have been asked. All of them they have been asked multiple times. So drugs causing bone marrow suppression, right? Drugs causing bone marrow suppression. I'm really proud of all of you guys. All of you have given, most of you have given 99% the right answer. Right. Now this is an easy MCQ, guys. 37-year-old drug abuser presented to OPD with complaints of diffuse pain in abdomen, which is at time associated foul-smelling diarrhea, alternating with constipation. The symptoms started after his visit to a concert where he had some street food. Stool examination revealed the organisms given in the picture, which is very easy. I mean, every undergraduate knows this. He started on a drug to improve symptoms, but she came back to the OPD with complaints of green urine. Which of the following drug the patient was started on? Chalo, jaldi. Come on. What is the answer, guys? A, B, C, or D? What is the answer? A, B, C, or D? क्या है आंसर? What is the answer, guys? आंसर क्या है? जल्दी कमेंट करो. आंसर क्या है? देखो, जितने लोगों ने भी बी आंसर किया है, दोज हु हैव आंसर्ड बी, जितने लोगों ने भी बी आंसर किया है, आप मेरे जाल में फंस गए. मैंने जाल बिछाया था, मुझे पता था. आई न्यू लॉट ऑफ विल गो फॉर मेट्रोनिडाजोल, बट विल नॉट बी द आंसर. द रीजन बीइंग green urine is not a side effect. Green urine is not a side effect of metronidazole. Green urine is a side effect of nitazoxanide, and nitazoxanide can be used in cases of resistant giardiasis. So you can understand, one word can change the outcome, right? So that is the reason why I've told you multiple times, read the MCQ carefully before committing to an answer. Attentiveness, ये बहुत ज़रूरी है, right? This is very important. So guys, your answer is nitazoxanide. So nitazoxanide is an important drug. It causes green color urine. I've told you this in the lectures. A 6-year-old girl was brought to the pediatric OPD by her grandmother and complains of abdominal pain, perianal pruritus since 2 weeks. Grandmother also said she saw some worms in her granddaughter's stool yesterday. Cellophane tap swab was done. This is your clue, right? Perianal area demonstrated eggs as shown in the image. The kid should be started on. Again, is not a difficult one. Guys. So whenever we talk about antihelminthics, excellent. Unnati has made the right diagnosis. Very good, Unnati. Enterobius vermicularis. Enterobius Vermicularis is the right answer. And obviously, our answer of choice is albendazole. So remember, anti-helminthic drugs. Anti-helminthic drugs, you have to remember the drugs of choice. So I have encouraged you time and again. I've encouraged you always to write down the drugs of choice separately, in a separate page in your notes, in the last pages, and revise them, right? And second, the types of paralysis. So anti-helminthic, the types of paralysis, drugs of choice. These are two things which are asked. 32-year-old daily laborer who has migrated from UP to Delhi presented to Safdarjung Hospital with a diffuse skin disease. Right, you can see the skin disease in the image. On examination, there were macules, nodules, and plaques over her face, as given in the image. She was diagnosed, and an appropriate regimen was prescribed. All of the following drugs can be included in the treatment of the patient except. Is it clarithromycin, minocycline, ofloxacin, cotrimoxazole? So what is the answer, guys? A, B, C, or D? Dinesh Verma, see from where you can get my notes. I don't know. I don't have my notes per se. You can search in some Telegram groups or somewhere you might find my notes. So it's an easy one. It's not a difficult one, guys. So what is the diagnosis here? We are dealing with a case of leprosy here, and clarithromycin, minocycline, ofloxacin is fluoroquinolone. These are second line drugs which are used. Cotrimoxazole is an antibiotic. So is the answer here. Leprosy, excellent. Richapal Galva, you have given the right answer. Leprosy is the right answer. Cotrimoxazole has nothing to do with leprosy, right? A 56-year-old man was brought to the emergency department because of high-grade fever, sore throat, chills, dyspnea, generalized aches in his back and legs. His son is also having same symptoms for the last 3 days. A clinical diagnosis of influenza was made and treatment with most preferred drug was started. All of the following are correct statements regarding the drug except, right? So influenza. So whatever is the drug of choice, these are the statements, and you're gonna find out which is not correct, right? It has good oral absorption. Dosing is 75 milligrams BD for 5 days. Acts by inhibiting release of RNA from the nucleocapsid. Effective if used in early stages of infection. So which is not correct? A, B, C, D. Come on, guys, come on. Think. So you have to take some time. You have to take some time to let the information sink in and give the answer and see. Once you have done that, the right answers are following. Now, if you have half-baked information or knowledge, then you might think that option C is correct. It does. So basically, we are talking here about oseltamivir, isn't it, guys? We are talking about oseltamivir, which is the drug of choice for influenza, and it has good oral absorption. Dosing is 5 days, 75 milligrams BD. It acts by inhibiting release, but not of RNA, release of virus from the cell. So this is not right. This is wrong. Effective if used in early stages of infection. This is true about any antiviral drug. I mean to say any anti-influenza drug or even in coronavirus. So the respiratory viruses, right? Drugs are effective if given in the early course when the virus is replicating. Once replication is done, right, there is very less you can target, right? So neuraminidase inhibitor, so it inhibits release of virus from the respiratory epithelial cells, not the release of RNA from nucleocapsid. This is blocked by amantadine. Amantadine blocks the release of RNA from nucleocapsid, right? So guys, this all we are gonna do today in the MCQ. If you have any doubts, you can ask me, and you can see week by week, gradually, we have covered already 70% of pharma. So we are done with antimicrobials today at the end of the day, and gradually studying bit by bit, little by little. So some of you guys have asked me that you have joined late. So many of you have joined late in the second week, third week, fourth week, fifth week. What you need to do is you need to continue with me till the last week, and then after that, whatever is remaining, right? You can do that later, and you can watch the live sessions which are there in my YouTube channel. I have not deleted them, and I'm not gonna delete them. I'm not gonna delete them till your exam is over or until the next live session I have. So if you have any doubts, guys, you can ask me, or we can call it a day and relax after that, and you can go back to whatever you want to do, to revise, read, revise, or sleep, or etc., etc., whatever it is you would like to do. All right, fine, guys. So do you have some doubts? All right, so if you don't have any doubts, then it's okay. It's fine, because these topics are not much difficult. And let's call it a day, guys. And thanks a lot for participating in this live session. And I hope this weekly pharma is gonna at last solve the trouble of not remembering things by repetitive revision. You're gonna remember that. You're gonna do that. So until the next time we meet, guys, next Sunday we'll have a live session of endocrinology. I've shared the timetable. Till then, keep hustling, keep studying. See you next Sunday, 10 p.m. Take care. Bye bye. This is Dr. Ranjan with you.